Hello, and welcome to the Sarah Clinical Education's Oncology podcast. I'm your host, Kemi Obachini. Today's episode features expert perspectives on to treat or not to treat, assessing risk and treatment options in high-risk smoldering multiple myeloma. This episode is part of a larger educational program titled From Smolder to Strategy, Optimizing Early Treatment Decisions in High-Risk Smoldering Myeloma and Newly Diagnosed Myeloma. This podcast features Dr. Natalie Callander, Professor of Medicine and Director of the Myeloma Clinical and Cellular Therapy Program at the University of Wisconsin Carbone Cancer Center in Madison, Wisconsin, and Dr. Tom Martin, Professor of Medicine and Associate Chief, Hematology Oncology at the UCSF Medical Center in San Francisco, California. They will be discussing the diagnostic evaluation and risk stratification for high-risk smoldering myeloma, how to interpret evidence for early intervention, factors to consider when selecting patients for treatment versus observation, treatment selection and sequencing considerations, how to ensure treatment safety, optimal monitoring and supportive care strategies, implementation of optimal treatment approaches in practice, the shared decision-making processes and patient communication, as well as emerging therapies and clinical trials for patients with high-risk smoldering multiple myeloma. For more information on Dr. Callander and Dr. Martin, along with a link to the complete program, please visit the show notes for this episode. Now let's get started and hear what the experts have to say on this important topic.
Welcome to our podcast where we discuss topics in high-risk smoldering myeloma. My name is Natalie Callander. I'm at the University of Wisconsin, and I am so pleased to be joined by my colleague, Tom Martin.
Hi there, I'm Dr. Thomas Martin from the University of California in San Francisco, and I'm very happy to join Natalie for our discussion on smoldering multiple myeloma.
I think everybody here is familiar with the fact that we define smoldering myeloma as this intermediate state between MGUS and actual myeloma. And I guess in today's modern era of more sequencing, of genetic profiling, what diagnostic approach, Tom, do you think should be applied to distinguish high-risk smoldering myeloma from active myeloma, particularly if we're going to think about treatment?
So in my mind, when I think about somebody who has MGUS or smoldering myeloma, the first thing that puts them from MGUS to smoldering myeloma, my mind, is the bone marrow biopsy showing more than 10% plasma cells, or the M protein if it's more than 3 grams in the peripheral blood. When I have somebody with smoldering myeloma, the first thing is really to do a risk assessment. And I typically use the 2-20-20, where it's really looking at basically a bone marrow plasma cells, the involved, uninvolved free light chain ratio, and the number of plasma cells in the bone marrow. So greater than 20% plasma cells in the bone marrow is a high-risk feature. Having an M protein of 2 or greater is a high-risk feature, or having a involved, uninvolved free light chain ratio of greater than 20 is also a high-risk characterization. Now, if you have 2 out of 3 or 3 out of 3 of these, you are considered a patient who has high-risk smoldering myeloma. Using that 20-20 risk stratification, those high-risk patients have close to a 50% chance of progressing to active myeloma by the 2-year timeframe, which is pretty substantial. That's 25% per year risk of developing active multiple myeloma. And those are the patients we should consider. Is it time to intervene with some type of therapy? Do you just use 20-20, or do you incorporate FISH?
Well, there's a couple things to make a point. I think one is that at least in my mind right now, for patients who walk in the door clearly with what appears to be MGUS, and those are typically patients who have under 1 gram of monoclonal protein. And we know from old Mayo criteria that those patients who have an IgG monoclonal protein, it's less than 1.5 grams. their FLC ratio, if it's normal. We really don't want to advocate, in my mind right now, that every single person needs a bone marrow biopsy. So we're really talking about people who do come in the door with, like you said, the criteria that's easy to see by just lab testing, like the greater than 2 grams per deciliter of monoclonal protein or a high FLC ratio. That's important. If I feel that the patient should go ahead and have a bone marrow biopsy, absolutely, I am very interested in their FISH results because it's now been documented in a number of different studies that certain abnormalities seem to be associated with a higher risk of progression. A little bit of variation from study to study, but it does look like the presence of 1Q, either gain or amplification, the older cytogenic change 13q, either deletion of 13q or just monosomy 13 seems to be involved. Then there's 414 and also translocation of 1416. And some people would even throw P53 in there if it's present or not. And so I do think knowing those, in addition to the other serum markers that you mentioned, as well as the bone marrow findings, really help you identify patients who probably need to be considered even now for treatment.
I completely agree. The models can potentially be enhanced by incorporating some of the genetic information that we're currently receiving, and whether the presence of maybe a RAS mutation or a mutation or the APOBAC genetic risk, I think can potentially really enhance our ability to select out those patients, in my mind, with smoldering myeloma that actually have a genotype and phenotype that's more like active myeloma. They just don't have that bulky disease at that point.
I think that's an excellent point, Tom, because we all know that risk stratification continues to evolve. And I think there have been people who've commented that the sort of high-risk smoldering group of 15 years ago is actually kind of a different group of patients, since now we do so much advanced imaging. We are sort of excluding, we went through the change in 2014 with Slim Crab, those patients with the FLC ratio above 100 or higher plasma cell percentage above 60, they used to be included in our smoldering definition, and now they're out. So that grouping is a little bit tighter. But I think we are going to see in the near future things like the inclusion of RAS mutations that does seem to be important, MYC and the APOBAC, and then I think some combination of sequencing may end up happening on a routine basis as these tests become more available to us as practitioners. Right now, I am not routinely sending sequencing. I don't know if you are, Tom.
Not really, not for smoldering myeloma. For active myeloma, we have been doing the sequencing panel so that we can pick up those patients that have the new IMWG high risk definition.
One of the most important things that I think we've all learned in the last 10 years or so is how important whole body examination of some sort is. We have a lot of choices. You can do whole body MRI, you could do a PET CT, or a low dose whole body CT. Do you have a preference if you see a patient with smoldering myeloma, which one of these you're going to use?
I actually do. I usually use a whole body MRI. And I think it's able to pick up these bone marrow lesions, these small focal bone marrow lesions, better than any other modality. So I do choose a whole body MRI. And again, if they have 2 or more, then that actually fits the definition of Slim Crab. And they would be then in the active myeloma category, and I would start therapy on somebody like that. How about you?
Well, we have a kind of intervention in our institution where we've been studying PET MR, and so we do those as well. A lot of the studies that are underway actually call for a PET CT. So we usually do a combination of MRI and PET CT depending on how we're going to triage that particular patient, whether it's going to be for a study or whether it's going to be for maybe what we would explore later, standard of care treatment for high risk smoldering. I think the study that we don't do here is low dose whole body CT. I think there are some limitations. Just like you said, you're not going to see the marrow lesions potentially, and then you probably would see some extramedullary disease if it's big enough, but I think that we've been more in the same ballpark that you have been in terms of a whole body MRI. Now, I know that we're all still trying to get used to the 2025 IMWG high-risk myeloma definition. This isn't really something that's moved into smoldering myeloma at this point, although people are scrambling to go backwards and see if we can analyze patients using that high-risk definition. But I haven't seen any large data sets. I don't know if you have, looking at that sort of reevaluation.
No, but I do think that all the smaller reevaluations that they're doing with the new IMWG high risk definition suggest that it actually does pull out a group of patients that are having lower progression-free and overall survival than those that don't have the high risk features. Just to review, it now includes patients that have a chromosomal 17 deletion
Right.
or a TP53 mutation, and it's typically in greater than 20% of the cancer cells. Patients can have the 414, our typical 414, 1416, or 1420 translocations, but they're only considered high risk if they have a co-occurring chromosomal 1 abnormality, either a 1q gain or a deletion of 1p. And then if you have both a 1q gain and a deletion of 1p, you're also considered high risk. And then in there is also elevated beta 2 microglobulin. So those people that have high beta 2 microglobulin are still considered high risk. So we do send the p53 mutation these days. The rest you can pick up by FISH testing.
And I think it's interesting, with just that beta 2 elevation, that we're still using that old definition, and even reevaluations of older studies have shown that those ISS3 or revised ISS3 patients still seem to do worse off than others, based on that beta 2. But of course, now we know that that needs to be interpreted in light of a normal creatinine, since of course that just gets pushed up by that. Let's take a look at some of the evidence out there for early intervention. We had a number of studies going on years ago that were trying to look at the drugs of the day. So that included things like thalidomide. There was an older study with melphalan and prednisone for smoldering myeloma, and none of them really showed any particular benefit. In some cases, maybe more of a detriment. So now that we have better choices for drugs, are you considering treatment coming in any particular interval that you think is appropriate? What do you pick?
That is just a hot topic in myeloma, isn't it?
Yes.
First things first is really to assess the risk status. And those, for
Mhm.
my patients that have low risk smoldering myeloma, I'll usually do their laboratory values every 3 to 4 months routinely. I usually will not repeat a bone marrow biopsy. In terms of a MRI, I may actually repeat an MRI, but if the labs are all completely flat, meaning they have non-proliferative disease, I typically won't even do that. I'm just doing Q3 to 4 months. Now, patients that have high risk smoldering myeloma, and I do like to follow them over time versus take an individual assessment and say, okay, you have high risk, let's start your therapy tomorrow. And for people that have truly high risk, high risk by the 2-20-20 model and potentially high risk FISH, I will follow their labs sometimes, as frequently as every 6 to 8 weeks, with bone marrow biopsies yearly and potentially an MRI either yearly or potentially twice a year if they really have high risk disease. How about you?
Well, I think this is also interesting that there's a wide variation in practice that I've seen talking to colleagues. I think we all agree that if people have what you want to call an evolving pattern, so let's say, between the intervals, their M protein or their light chains are going up maybe 25% or more. I think that's an easy call to have those patients maybe in every, as you said, every 3 to 4 months. I think for patients who are originally deemed to be low risk, I tend to have them come back for another visit, maybe in a shorter interval, 4 months, just to see if they're evolving or not. And then, just as you said, to try to back them off maybe to 6 months. Where I think it's controversial right now is just as you said, how much are you going to marrow these individuals? How much are you going to scan these individuals? I know some colleagues will do it yearly, just across the board. And I don't know if we have enough evidence to recommend that routinely for patients. Certainly, if they have an evolving pattern, I think that makes sense. But just like you, I am not routinely repeating marrows on patients. What is also very humbling in this particular group of patients, and I'm sure you've seen this many times, is the smoldering person who actually on their next visit, their M protein is lower. And I've certainly seen that where you just sort of feel maybe it was a good idea not to intervene or not to consider perhaps jumping the gun a little bit. But that's where I think, we mentioned the molecular profiling. They may help us tease out the patients who really don't need intervention in the long run. For people who don't see many smoldering myeloma patients in their practice, do you think that at the time that they initially walk in the door that we would do that bone marrow biopsy like we talked about, we would do some FISH and cytogenetics if you have molecular profiling potentially available, and then let's say that they fall into a low risk group, what would you then recommend? When should their next visit be?
I usually will do the labs again every 3 to 4 months initially, and then I'll see them back in 6 months just so that I at least have a second or a third lab value to try to see, as you just discussed about the evolving phenotype. Those people who are, their M protein is going up fast, and they need to also remember that we have to follow the serum-free light chains. Those that have M proteins that are rising, you do have to wonder if that actually is going to be active myeloma in the short span within a year. And you can consider therapy at that time, or at least make sure you're following them close enough so that you can intervene before they develop hopefully before they develop any slim crab or severe, complications of active multiple myeloma.
It's time now to think about patients who we think need treatment versus those that we can observe. It's helpful to just take a look at some of the older trials that kind of laid the foundation. I think most people are very familiar now with the Quiridex trial that came out in 2013. A small study, 119 patients, randomized to either lenalidomide with dexamethasone for up to 2 years. Dexamethasone could be restarted if there was evidence of progression versus observation. And while this study had both a progression-free and overall survival benefit for those receiving lenalidomide and dexamethasone, it really didn't trigger a big tidal wave of moving to lenalidomide intervention. And probably that has to do with, I think, some concerns. Around the time that this study came out, there was more concern about secondary malignancy signals in the lenalidomide post-auto use. And then I think the other concern is that this study probably did contain some patients with actual myeloma based on the era that it was developed, and it did not require advanced imaging. But, along with that, then some years later, we had the ECOG study, E3A06, that actually randomized patients to just lenalidomide alone versus observation. And in this case, the lenalidomide was given until progression. This study did require advanced imaging, but because of concerns about the enrollment numbers, the entry criteria was changed sort of halfway through the study or so to include actually low-risk smoldering myeloma. And the study did complete in the conclusions after about a median 3-year follow-up, where that progression-free survival was significantly enhanced by the inclusion of lenalidomide, meaning the hazard ratio, I think, was like 0.24. It was quite striking. But once again, lenalidomide was not really adapted, I think, in big numbers by the community. Do you have any thoughts about that? Why that occurred, or why that didn't occur, I guess?
Yeah, I mean, you spoke to the issues, and that are important when we think about treating smoldering myeloma. These are asymptomatic patients. And so with every patient, you have to think about risks and benefits. What are the risks? What are the side effects? And then what are the benefits? Now, none of these studies have actually shown curative potential for treatment for smoldering myeloma. And that's important. So with the Curidex and the ECOG study, both using lenalidomide has side effects, right? It has some significant side effects. Fatigue, especially taken over time, GI toxicity. They have problems with cytopenias. And even some patients in those trials, when they did develop myeloma, they had difficulty with collecting stem cells. So I'm not a big fan of using lenalidomide-based therapy in general, especially until progression in patients that have smoldering multiple myeloma. And so I think I think most of the community feels the same way about that. Now, the Aquila trial is a big difference. I'm curious what you think about the Aquila trial observation versus, the anti-CD38 antibody daratumumab for a time limited period for 3 years. And its daratumumab is actually pretty well tolerated. In terms of the risks, the biggest risks with daratumumab are the risk for infection. And perhaps there's a little bit higher risk of grade 3 or 4 pneumonias in patients receiving daratumumab than patients in the observation arm. But at 60 months of follow-up, the median progression-free survival was 63% in the daratumumab arm, and it was 41% in the observation arm. And so that led to a 50% reduction in basically the progression to slim crab, which I thought was pretty substantial. What did you think about the Aquila trial?
The Aquila trial is the largest phase 3 trial to date conducted in smoldering myeloma, 400 patients, which is pretty impressive. Then, as you said, the fact that this is time-limited therapy. The other thing is sometimes timing is so critical here because since daratumumab was introduced in 2015, most people who treat myeloma patients are quite familiar with it and quite comfortable with it. And of course, the other advantage here is that this was the sub-Q formulation. And so I think that toxicity, you didn't have all the infusion-related side effects that we know used to happen when we were using IV. And I think for those reasons, this kind of therapy, particularly going to monthly at, month 8, I think everybody's pretty comfortable with that. And so I think that this has really been a game changer. And I think one of the things that is pretty clear, at least in the first couple of analyses that have come out, including the update that just occurred at ASH by Pete Voorhees, it still looks like maybe this therapy should be confined to higher risk individuals. Now that, the definition of high risk in this study varies from other studies, but nonetheless, those patients who met that high risk 2220 definition when it was analyzed really seemed to benefit the most. And even those who had the intermediate also did in terms of their PFS. And I guess the other really striking thing about this study, you sort of alluded to this before, is they have the overall survival statistically significant result, which Queerdex did, but in this study, I think this was really seen as just as you mentioned, a game changer.
Yeah, I was really impressed also by in both arms in the daratumumab arm, 20% of patients progress to active myeloma and required therapy over 24 months, whereas it was 40% that progressed to active myeloma in the active monitoring arm, which is, that's a big difference when we talk about smoldering multiple myeloma. So who's your candidate to receive daratumumab for high-risk smoldering multiple myeloma? What risk factors do you say this person should get daratumumab?
We're still trying to put people on trials. The more rigorous we can do interventions, the better off everybody will be. But having said that, what I see more and more is, maybe you've noticed this in your practice, but I think people in the community are embracing this. And so I think they're not even necessarily sending the patients for us to weigh in as to whether they think using daratumumab is a good idea or not. I think there are a lot of people, like I said, they're just so comfortable with daratumumab. They just feel like this is something that they know, they understand, they can explain it well to patients. I think they're very comfortable with it. Now, in terms of my own practice, I think we've seen a few individuals who have been sent in to say, do we agree with the plan to start them on daratumumab? I try to make sure that the practitioners pay some attention to the hypogammaglobulinemia you're going to get from daratumumab. And you do need to make sure that patients, at least in my opinion, get some prophylaxis for zoster, we tend to put people on Bactrim as well. I do think that's something that people need to understand. That is probably going to happen as a result of the treatment, that they will have perhaps even more immunoparesis than they started off with at the time of their original diagnosis of smoldering.
Yeah, there's certainly very strong evidence for delaying progression to active myeloma.
Absolutely, yeah.
The study. I personally, like you, I'd rather treat patients at the current time on a clinical trial if we have one open and they fit the high risk criteria. the trials that you discussed didn't really have a uniform high risk definition, and it was none of those were really truly all the 2020 high risk patients. But if you just take those 2020 high risk patients, they all benefited from treatment versus observation. That is, I think, an important part. It's pretty easy for me in a high risk smoldering patient to think about and to discuss daratumumab. I probably do it more commonly in an older, perhaps less fit patient that I think daratumumab is a great study or a great treatment that they can tolerate without, many side effects. I still am a little nervous in the younger, high risk patient, especially someone that might have, abnormal FISH or abnormal genetics. Is daratumumab by itself, is it enough? Should I wait and give them the 4-drug combination? I'm curious what your practice is.
There's been this tension in the treatment of smoldering myeloma if you decide to treat between what we hope is sort of resetting to maybe an MGUS-like state versus really taking more of a curative approach or an elimination of the clone approach. And so the studies that have had the more aggressive treatments, just to mention a few like GEM-Caesar, where they were using induction with KRD, with carfilzomib, lenalidomide, dexamethasone, and a stem cell transplant followed by some consolidation, and then lenalidomide and dexamethasone maintenance, they were able to show some very exceptional MRD negativity when they have done longer term follow-up, but there's been a price to pay in those individuals. There were some early deaths from toxicity. And, I think we're going to continue to see that kind of approach evolve. There's also Shaji Kumar recently updated his ASCENT trial, which was carfilzomib, lenalidomide, dexamethasone, and daratumumab. Pretty intensive 2-year program. This is a phase 2 trial, and they showed a progression-free survival that's impressive. But I think we may need to see more time go by for that approach as well to say whether that should be considered standard of care, particularly in a younger individual. It did not contain the stem cell transplant, which I think probably people would be in many ways more comfortable omitting at this point.
In smoldering myeloma, there are, even in high-risk smoldering myeloma, there are some patients that it would be years before they progress. Right. Are we over-treating some patients? And then with daratumumab, are we under-treating them without giving them a triplet or a quad-based therapy? And so it's a big decision between the physician and the patient on, when to move forward, and also, what therapy to use when moving forward. There is out there too many other studies. There's doublets of Lendex versus the triplets of the CD38 antibodies with Lendex. So we have daratumumab Lendex, we have isatuximab Lendex. And then, like you said, there's other immunotherapies that are really showing quite a lot of promise in this domain.
The dynamic right now is really trying to figure out, is there really the opportunity here to completely prevent myeloma progression and not cause any sort of long-term side effects, or maybe kind of an alteration, immune alteration, if you want to put it that way, that would in the long run be detrimental. No one should take away from this discussion that we're advocating across the board intervention for every smoldering patient. There are definitely people who are going to benefit from sort of sitting on the fence, or sitting on their hands. We don't want to imply that every single smoldering patient needs to go right into therapy right now. I think that there are, I have many patients that I continue to follow who have maybe 0 or maybe 1 of those 20 through 20 features that I think right now that we still should just observe them. So Tom, I have a question for you. And this has happened with a couple of patients. Let's say you have a person who is getting maybe daratumumab off protocol, or perhaps even lenalidomide, although you said you don't use that very much. If they start to show some signs of progression, meaning their monoclonal protein goes up, what's your strategy for handling that situation? And let's say they still have no myeloma defining events at that time.
In the IMWG, we discuss a couple important things. One is, when you start somebody with smoldering myeloma on therapy, they haven't really reached the definition of active myeloma. And so the worry is that you're going to limit the options, especially options for clinical trials down the road. And we've discussed that we want to make sure we include patients in clinical trials that have been treated with smoldering myeloma, and that we should all try to define eligibility that allows enrollment so we can actually answer the question that you just asked. That said, if somebody progresses on daratumumab or progresses on CD38 antibody, then probably I will not use the CD38 antibody potentially for the next induction therapy for multiple myeloma. I actually would choose the triplet. Probably I would give them the triplet, our standard triplet of lenalidomide, bortezomib, and dexamethasone, or VRD. And I would start there. If they're transplant eligible, I would take them to transplant. And then I potentially would consider lenalidomide maintenance, or if they were high risk, I would consider a 2-drug maintenance, and that could be lenalidomide plus daratumumab or CD38 antibody. It could be lenalidomide plus bortezomib. It could be bortezomib plus daratumumab, depending on what they've tolerated with their regimen. So I do try to limit re-exposure right away if they have progressed on that therapy. How about you?
I think that approach makes sense. This is something I really struggle with. I mean, I think it's an easy call if you see a person who's sort of ratcheting up and maybe, their hemoglobin isn't quite less than 10, but it's clearly going down. I think you can sort of say that person should be moved over to real myeloma type therapy. But I am paying close attention to the trials that are allowing retreatment of a smoldering patient who is still smoldering with a different intervention, because I'm very interested to see how those patients ultimately do. And, as we know, the treatment for active myeloma is changing so quickly. In the long run, does it benefit those patients to not, I guess, if you want to use the analogy, pull the trigger, so to speak, for myeloma treatment, and whether they are just better off in the long run going through maybe another iteration of smoldering treatment, whether that's with a trial or off trial. I have to say that I'm sort of kind of in favor of that, but I absolutely understand for those patients who look like they are really ramping up their protein levels to take them and say, this is close enough to myeloma that I'm going to treat them that way.
If we further dig into, treatment selection and sequencing considerations, we think about, what are the important factors to consider to appropriately select the right patient in the right sequence of treatment. And these will include, disease-associated factors like we've talked about. Do they have the genetic profile of somebody that has high risk as well as high risk smoldering myeloma? Also, patient-related factors. Are they frail or are they young? Are they fit or are they not fit? I think logistics plays a little role in it, like distance to the treatment center, and obviously comorbidities. In some patients, you want to avoid dexamethasone because they have bad hypertension or they have hyperglycemia, difficult to control sugars. The daratumumab or regimen is a pretty good regimen because it's very limited steroids. It's just steroids in my mind, for the first couple doses, and it's done. And then there are treatment-related factors. And I'm curious, what your approach is, Natalie, with somebody that has the high-risk FISH and they have high-risk smoldering myeloma by the 2020. That makes me nervous to give them daratumumab or as a single agent.
Yeah.
How do you treat that patient?
Well, I think our bias is we're trying to get everybody on the ECOG study. You mentioned sort of triplets, which is lenalidomide, daratumumab, and dexamethasone versus lenalidomide, dexamethasone. I think I do think that there's that steroid for a limited amount of time. That trial includes that, can be helpful. But I would agree. I think I would be a little concerned about daratumumab just on its own. Now that, if you dig into the protocol for Aquila, they did recommend a dose of steroid going through the entire 3 years with the daratumumab. I haven't seen a breakdown about how many of those patients actually got that for each of the doses over the 36 months, but I think that's kind of an interesting question. But I would agree with you that I think that may not be enough. Now, having said that, I certainly have had the experience, and I know this is not perhaps your favorite intervention, of that I've treated some individuals off protocol with lenalidomide. In the several cases that I've done this, these are individuals who just cannot get to our center in any, or really anybody's center, because of some family considerations. And I've actually found the lenalidomide pretty easy to do at lower doses. So I still have that in my, I guess, my back pocket as a consideration for patients who just cannot get to clinic and do it on a time limited basis. And I've had what I would consider some very good results. Again, not necessarily putting them in remission, but controlling them and putting them back to sort of an MGUS-like state.
And you said time limited. Do you do it to they achieve a plateau?
I started doing this, I guess, in my own practice when Quiridex came out, and so I've kind of copied that, I guess I would say. So I've usually tried to limit it to 2 years, and I also have certainly appreciated for the E3A06 for Sagerloniol's trial, the median time that people were able to stay on lenalidomide was about 2 years anyways, and so I just sort of feel like that's kind of the realistic approach. So that's what I've done, and I haven't really treated to maximum response as you're suggesting, but you know, that's been my practice to try to kind of adhere to the studies that are out there.
Oh, great. So let's talk a little bit more about safety and supportive care that you use for the smoldering myeloma patients. You had talked about earlier that daratumumab single agent is associated with a higher risk of pneumonia, and you had mentioned IVIG. So I'm curious, do you use a level in the blood lower than a certain level that you give them supportive IVIG, or will you only do it in patients that had pneumonia or had a bacterial infection or recurrent bacterial infections?
We all started using daratumumab either singly or in combination, going back to the first studies that came out. For the smoldering individuals, I am not routinely prescribing IVIG if they're getting daratumumab, unless they are having a grade 3-4 event and their IgG level is falling below 400. IVIG is a wonderful option to have. It is not a perfect intervention, as I'm sure you're aware. It doesn't prevent all infections by any means, but I think for a person who's had certainly a hospitalization for a respiratory event or another infection, I would certainly consider it.
And you had mentioned prophylaxis, acyclovir and
Right.
VZV prophylaxis. I usually use VZV prophylaxis when they're on steroids. Otherwise, probably I won't use PJP prophylaxis. There was data in the first couple cycles of using an antibacterial
Right.
oral regimen like Levaquin for the
Yeah.
first couple cycles to prevent bacterial infections. Do you ever do that in smoldering myeloma?
I have not. I think the way our ECOG trial is set up, you have an option to consider it if you want, but it's not mandatory. We actually have done that now much more aggressively than we used to, because we've had a few situations where we had, within the first couple of cycles, some early, really serious life-threatening infections in people who are not getting that. So I would say, Levaquin prophylaxis or something similar to that. We're doing an active myeloma, particularly if they're on quad therapy. But in the smoldering space, we're not routinely doing it outside of clinical trial unless it's mandatory.
And then what about bone targeted agents?
Yeah, I'm very influenced by older studies that really didn't show any benefit for that. And so I know that there's some Scandinavian data that has suggested that there is some bone disease in people. I think in particular, they were looking at individuals with MGUS. While I think that's kind of interesting research, we have not routinely done it. And there's some reasons why, I'm not sure that everybody should be on bisphosphonates. How about you?
For us, we do check a bone density. I think it's reasonable to check a bone density. And
Yeah.
if they do have, osteoporosis, then I will start a bone
Okay.
targeted agent. If they have osteopenia, then pretty much we
Yeah.
recommend vitamin D and calcium replacement. Try to do as much exercise as possible. And then we'll repeat
Yeah.
it, in 2 years and see if that has made any improvement in their bone density. At least it's not getting worse. Any other recommendations for community practices to kind of operationalize this risk stratification with imaging and cytogenetics and specialty care, et cetera?
Well, I think I think we want to take home the message here that it is that the simple tools that we have are very useful. The 2220, people sort of go, sort of maybe feel like it's too simplistic, but it's really stood up pretty well in these reevaluations. So I think that's a a way to risk stratify that's available essentially to everyone. And so I think you could start with that. If you do the bone marrow biopsy, absolutely pay attention to the FISH and cytogenetics to further refine the risk stratification. But I feel like those are very easy tools along with the advanced imaging. And I think if weed out those patients who clearly have active myeloma, you're doing a real service to your patients. If you find a patient who just is purely high risk, I would still want to try to get them on a trial if at all possible. But I do think that there is sufficient data now to consider daratumumab for those high risk individuals. And again, I would say based on the older data, I would not take lenalidomide off the table either.
It's very difficult with the high-risk smoldering myeloma population, in that you can follow them as close as possible with
Right.
6 or
Right.
8 or 12-week
Yeah.
M proteins with bone marrows and X-rays, but they can come in with a
Right.
fracture,
Right.
or they can come in with renal insufficiency or hypercalcemia, where they really feel bad, and that's
Yeah.
a hard nut to swallow when you knew,
Right.
man, if I just had started that agent, they
Right.
might have done better. It's hard to watch people actually progress. It's really getting the experience of seeing more and more patients to try to decide what you're going to do and when you're going to do it.
I think along those lines about whether we can now apply our more potent interventions that we have for treating myeloma to smoldering. And I think there have been a couple of very interesting studies that have been presented. We've got now, I believe, 3 different trials that have looked at bispecific engagers in smoldering myeloma. There was the initial immunoprism that I think was about 19 patients coming out of Dana-Farber. We now have the linker 1 smoldering trial also looking at patients with a high risk either by 2220 or the Pethema high risk. And then, of course, there was the very recent Erasm study presented at ASCO and also updated just a little bit at AHA. That I think is the largest now bispecific trial that has 50 patients in it. And, those results are very interesting, and the MRD rates are very high. The response rates are very, very high, but I think you would agree that what we really need to see is longer term follow-up to see, not only is that something that sticks, is that intervention helping, but is it also not, we hope, creating any long-term problems for patients who end up becoming more resistant.
I'm quite impressed by some of these
Yeah.
bispecific trials, especially at ASCO, hearing
Right.
about the EMN34 trial.
Yeah.
The one thing that really I think we need to better address is time-limited therapy. I know it was 24
Right.
months for the study.
Yeah.
And, the overall response rate was over 90%. More
Right.
than 70% of the patients
Right.
are in complete response, and 90+% of patients are MRD negative. And those responses are going to deepen over time, which is amazing. And I actually do think they're much better tolerated than the lenalidomide combination, but there is that signal of infection that we have to worry
Right.
about.
Right.
So I'm very curious on where bispecifics are going to go, and what, do we just need 3 months? Do we need 6 months? Do we need 12 months? What is going to be the best time? But
Right.
the other study that I did want to mention is, the Boston group, Dr. Nadim and Dr. Gobriel just published a study using ciltacabtagene, or cilta-cel, a CAR T cell therapy, in those patients at high risk smoldering myeloma. And this trial showed an MRD negativity rate of 100%. Right? And then the majority of patients have achieved a CR and are MRD negative. However, there were side effects, right? So 7 of the patients developed these late neurologic toxicities. 4, they were cranial neuropathies. Those cranial neuropathies, they get better typically with steroids and IVIG therapy. But there were 3 patients that developed Parkinson-like symptoms. Only 1 required intervention more than steroids and IVIG, actually got cyclophosphamide, got intrathecal therapy to try to prevent further progression. Now, all the people that had the Parkinsonian-like symptoms still have those symptoms. And again, this was an asymptomatic patient
Right.
population. So what do you think about CAR T cell therapy for
Well,
smoldering
I
myeloma?
think, and again, there's a lot of different things to look at in the trial. The thing that actually just you've underscored the neurotoxicity. What I also was impressed about is they had tried to deliberately select patients who they thought were going to have less toxicity. They tried to limit the amount of plasma cells in the bone marrow. They did not pre-treat them at all. There may be some take-home lessons in the future if this is explored, which it probably will be. What would you do to prepare patients better to try to eliminate that neurotoxicity? And I do think that this is not ready for prime time, and I certainly would not recommend anybody consider CAR T for smoldering myeloma at this point. And I think the neurotoxicities, particularly the Parkinson's, were sobering. But I suspect it's going to continue to be explored, particularly as we have other ways to deliver CAR T coming up in the near future.
Well, Natalie, this has been a
Yeah.
wonderful discussion. Your final thoughts, and then I'll have my final thoughts on to treat or not to treat, assessing risk and treatment options in high-risk smoldering myeloma.
Sure. I think we just have to get in the practice to the best of our ability, trying to stratify these patients. I think it doesn't take that long with the 2220. I think the bone marrow fish and cyto is helping. Hopefully, sequencing is going to be added in this near future. But I think we want to really watch those patients first before we just uniformly recommend treatment for all of those individuals. I don't know what your opinion is about that.
It's same thing. I think you and I do things very similarly.
Yeah.
To treat or not to treat, that is really the main question in smoldering myeloma. And it ends up being a long discussion with the patient.
Right.
It is so important that we take each individual patient with smoldering myeloma, watch their movie in my mind, rather than taking an individual time point and saying, okay, you have high risk, let's get going. And I do think that the 220/20 plus fish is a great way to differentiate those people that truly have high risk smoldering myeloma. A 50% chance within 2 years of progressing to active myeloma. Those are the patients that I do think you can think about initiating therapy. When you're considering therapy, really the best tolerated one so far has been daratumumab. And it's approved in high-risk smoldering myeloma, 3 years of time-limited therapy. And you just have to watch them closely with supportive care measures, antibiotics for infections, IVIG. I would say only if they have infections or if their level goes real low, less than 200, I would generally give it to them. And I think we're all waiting for the immunotherapies, right? These immunotherapies may actually end up being a way that we can really reset the clock on smoldering myeloma, hopefully back to even a pre-MGUS state.
Yeah.
Last thoughts, Natalie.
I would agree with that. I think one area that we still need to explore is not just the plasma cells that are the problem in smoldering. It's probably the microenvironment too that we have to understand a little bit better. Lots and lots for us to continue to work on here, but I share your optimism that in the near future, we're going to take these patients and keep them from ever developing myeloma, which is, of course, the goal.
Thank you very much, Dr. Callander and Dr. Martin. And thanks to you, the listeners, for joining us. As a reminder, to view the full program on From Smolder to Strategy, Optimizing Early Treatment Decisions in High-Risk Smoldering Multiple Myeloma and Newly Diagnosed Multiple Myeloma on the DESERA Clinical Education's website, please click on the link in the show notes. As always, thank you for listening.